my name is Sadler. Welcome to my practice improvement project. So, mental health screenings are not routinely conducted upon admission of adolescent patients unless the admission is directly related to a mental health condition. Therefore, it's unknown by inpatient providers if mental health is a factor in a patient's current health condition and whether there is underlying anxiety or depression that should be recognized and treated. Karcher and colleagues stated that screening tool implementation is more critical now following the COVID-19 pandemic, with significant increases in positive screenings at primary care offices. Approximately 56% of patients provide a positive result. This article recommended improving and expanding the early identification of pediatric mental health concerns. My goal is to incorporate these screening tools on a regular basis in the inpatient setting. In addition to these patient care implications, workflow issues can be identified when patients are not screened. These include a lack of routine screening from hospital to primary care because there's insufficient documentation, poor or delayed referral coordination, inability to monitor patient trends and screenings over time, and without screenings embedded into the admission workflow, providers forget or skip screenings altogether. The proposed solution is an integration of the PHQ-9, or Patient Health Questionnaire, and Generalized Anxiety Disorder, or GAD-7, mental health screening tools into the EHR admission set for adolescent patients being admitted to the acute care unit. The purpose of this technology is to prioritize mental health screening for adolescent patients being admitted to the hospital to adequately recognize anxiety and depression and treat as necessary. The FIT model was used to analyze how this technology would fit into this organization, starting with its fit for individuals. Providers know these screening tools. They're straightforward and easy to replicate. It assists providers in being proactive with their comprehensive care decision-making. During the sometimes lengthy admission process, numerous topics are discussed. By adding these tools to the list, a more thorough discussion during admission can be conducted. In regards to the task fit, because the technology would be an addition or update to the already existing EHR order, providers should experience a seamless transition in using this tool when they follow their admission questions. Possible interoperability gaps include if the screening tools are not appropriately integrated into the Epic order set, where the screening tool results cannot be viewed or replicated. Like other admission tabs, these tools should be retrievable to all providers and nurses, and additional screening should be able to be conducted afterwards. For the technology fit, the general technology is already in place for a standardized admission order set for providers to add to patient encounters. So it's a matter of updating this order set to include the two screening tools. Per the Epic software information page, this comes at no direct extra cost, but there is a time cost for the Builder ClinDoc analysts to update the system. Safety Starts Here is the safety initiative developed by the organization. It promotes identifying and removing barriers to success and turning potential errors into learning opportunities. The problem at hand is undoubtedly a safety concern to children with unidentified mental health illnesses. By integrating screening tools into the admission workflow, the organization's goal of elevating healthcare for every individual is supported. Primary data sources will be those collected directly from this project. They would include the rate of screening completion via the patient chart. Another would be the number of positive screening results and appropriate referral and treatments. Surveys of staff knowledge and satisfaction with the ease of tool usability could also be collected and used to determine barriers. Rather than new collected data, secondary data may also be used, which is data that already exists to help demonstrate the need for the practice change. This could include the current rates of compliance of the Edinburgh screening tool used in the postpartum unit in the hospital to detect depression. How is the Edinburgh screening tool incorporated into their EHR flow sheet? And what is the interdisciplinary collaboration with behavioral health for these new mothers? Although very different from the problem at hand in this presentation, collecting secondary data on this screening tool would provide good insight and information on effective implementation and overall impact. Another secondary source could be the EHR data, finding out how many adolescents in the past 3 months were screened for anxiety and depression or got a new diagnosis while admitted. As stated before, the proposed solution is an integration of the PHQ-9 and GAD-7 mental health screening tools into the EHR admission order set for adolescents. When the admission order set opens, it prompts the provider to screen using the two screening tools. When the screenings are done, the results will populate automatically, and if positive, a suggestion to refer to a behavioral health specialist will appear. By integrating this tool, providers can immediately begin assessing for mental health conditions and promptly start treatment through referring to a behavioral specialist in the hospital. Because this is an addition to the admission workflow, the actual process and order sets of admitting a patient does not change. The screening tools are easy to use, take only a few minutes, and provide great insight into the adolescent patient's mental health state. A few measurable outcomes that will be monitored and evaluated during implementation are, number one, how many patients are screened? What is the usability of the tool? Number two, how many patients were appropriately referred to a behavioral health specialist based on their screening results? Number three, how many patients were actually diagnosed with a form of anxiety or depression? Short-term goals for the first 3 to 6 months include training all the nurses and providers on the new tool. In regards to tool usability, I would aim for it to be utilized 90% of the time. More than 90% of the time, I'd aim for consistent documentation of the screening tools with minimal errors on the patient's chart. And lastly, in these first few months, I aim to see a boost in referrals to behavioral health, ideally at an increased rate of 60%. Long term, my first goal would be an increased rate of anxiety and depression recognition and treatments by 50%. Upon discussions with staff, I would aim for a normalization of screening for mental health. Improved interdisciplinary collaboration is another long-term goal that would be determined by conversations with the different pediatric teams. And ultimately, a reduction in the number of acute or severe admissions for anxiety and depressive episodes by around 10 to 20% is another long-term goal. As far as stakeholders, providers, including physicians, residents, and APRNs, will be initiating and ordering the order set. They will implement screening tools during their admission assessment, obtain results, and create a plan as appropriate for the patient. Nurses will help carry out the mental health care plan, coordinate consults, administer treatments, and assist in reassessing patients during admission if repeat screenings are deemed necessary by the provider. IT staff will integrate the tools into the admission order set and work towards optimizing the overall seamless workflow of the screening tools in the patient's EHR. The feedback from these key stakeholders will assist in determining how effective and efficient the updated technology is on a day-to-day basis, how feasible it is from an IT standpoint. A conflict of priorities could be the patient's admitting diagnosis and current health acuity state. Of course, depending on how acute the patient is, screenings may be conducted at a later date when the patient improves and has the capability of answering the questions. Additional conflicts could be the provider time constraints to complete the admission assessment and the availability of the behavioral health team pending a positive result. For patients, possible illnesses will be recognized and mental health support may be provided and prioritized along with their admitting healthcare diagnosis needs. Hauschild and colleagues describes the software development lifecycle as a beneficial way to pave the way for deploying improvements in clinical practice. The first step is planning. Here, we recognize that anxiety and depression screening tools are not routinely conducted. During this phase, baseline screening data will be collected, evidence supporting the screening tools will be dispersed to key stakeholders, and approval will be sought from unit and hospital leadership. The analysis phase is next, which will help with assessing system and workflow requirements. On this unit, the nurse practitioners and residents complete admission documentation, so the EHR does not have screening prompts and no screenings are consistently utilized, so behavioral health specialists are underused. Identified requirements include embedded screening tools for adolescent patients, automatic scoring of results, alerts for positive results, and straightforward workflows to refer to behavioral health. During the design step, it can be determined how the workflow will be updated, such as admission order set opens, prompts provider to screen using the tools, the screening is done, the score results automatically, and if positive, a suggestion to refer to behavioral health will appear. Next step is implementation, where IT builds the workflow in the order set. Training is given to nurses and providers, educational flyers are placed in the staff break room, and the updated workflow goes live. The testing phase ensures the new tool is functioning properly and safely. Is the correct age group being screened? Are the results automatically computing, and are they accurate? During the evaluation step, the effectiveness of the workflow is determined. Data will be collected and analyzed on the percentage of the patients screened, the rate at which patients are referred, percentage of patients who received a new diagnosis of anxiety or depression, and those who received treatment. Additionally, how was staff compliance, and did staff find it easy to implement? For ongoing use, it's lastly important to assess the maintenance of the updated admission order set. To sustain improvements, some maintenance tasks that could be done are monthly monitoring of screening compliance, providing refresher training on the importance and use of the screening tools, and update the tools based on evidence and guideline changes. As obstacles arise and staff report issues with the tool, further adjustments may also be made. HIPAA protects the patient's electronic health records and identifiable health data. Just like any quality improvement or evidence-based change made in practice, it's essential that HIPAA is prioritized and maintained for all patients. This technological solution is a change to the EHR order set, which is on a secure, password-protected platform. Only healthcare providers who are involved in the care for the patient may access the patient's EHR. In regards to culture and organizational readiness, the hospital staff are eager to provide the best patient care. Even recently, they changed their formula protocol for tube-fed patients, so formula is now a medication in the MAR. Leadership in the hospital and unit will be very influential in this project. On the nursing and provider level, these leaders will not only be pivotal in approving the proposed solution, but carrying it out and promoting it on a day-to-day basis until it's routine. There will also be cultural influences from patients, families, and healthcare staff. These include their personal perspectives and possible stigmas on mental health. Using a change theory or structured framework will be crucial for guiding the planning, implementation, and evaluation of the solution. Conversations with stakeholders discussed previously will need to take place to spread word of the current problem, its significance, and how it can be improved. After creating the vision and removing any barriers, we can celebrate short-term goals and build confidence in the updated workflow. Change theory improves staff acceptance, increases compliance, strengthens collaboration, and supports sustainability. As far as the impact on patient safety, the risk of poor health outcomes related to anxiety and depression increases when these conditions go unrecognized and untreated. So, placing these two screening tools at the forefront of a patient's admission as an automated workflow tool decreases the risk of missing opportunities to diagnose and treat mental health illnesses in this high-risk population. Bradford and colleagues discussed how missed or delayed diagnoses can lead to poor health outcomes and ultimately waste resources, including frequent hospitalizations for delayed diagnosis and treatment. This review found that 18% of child and adolescent anxiety disorders were missed by providers, and only 1% were false positives. In conclusion, the incorporation of these screening tools is meant to be a straightforward way to provide comprehensive care. In a setting where mental health often gets overshadowed, it's important we don't lose sight of psychological health. Children in the hospital are already overcoming the natural stress of being away from home and being surrounded by strangers. Underlying anxiety or depression would only worsen their experience and prolong their recovery time. By increasing recognition, providers may positively impact patient health outcomes through the multiple modes of mental health treatments. This supports the organization's goal of promoting health and preventing disease to people of all ages in our North Carolina region. And here are my references. Thank you so much.